Hello.
Bismillahirrahmanirrahim. Assalamu alaikum. Distinguished guests, we are going to start our inaugural ceremony. So we request humbly to please take your seats in Grand Ballroom A. সম্মানিত অতিথিবৃন্দ, আমরা কিছুক্ষণের মধ্যে আমাদের অনুষ্ঠান শুরু করতে যাচ্ছি। আমরা সকলের প্রতি বিনীত অনুরোধ রাখছি গ্র্যান্ড বলরুম এ তে এসে নিজ নিজ আসন গ্রহণ করার জন্য। ধন্যবাদ। Ladies and gentlemen, we are going to start our inaugural session very soon. So here we request all of you to please come inside Grand Ballroom A and take your seats. সম্মানিত অতিথিবৃন্দ, আমরা কিছুক্ষণের মধ্যেই আমাদের অনুষ্ঠান শুরু করতে যাচ্ছি। যারা এখনো বাইরে রয়েছেন তাদের সকলের প্রতি বিনীত অনুরোধ, আপনারা গ্র্যান্ড বলরুম এ তে এসে নিজ নিজ আসন গ্রহণ করবেন। হেপাটোলজি সোসাইটি ঢাকা বাংলাদেশের সকল সম্মানিত সদস্যদের অনুরোধ করব ভেতরে এসে আসন গ্রহণ করবার জন্য এবং আমাদের প্রস্তুতিমূলক কাজগুলো সম্পন্ন করার জন্য।
ওখানে পুরোটা দাও দেন। ওকে, আমার কাছে জায়গাতে সাথে জায়গাতে
Bismillahirrahmanirrahim. Distinguished guests, participants, ladies and gentlemen, Assalamu alaikum. A very good morning and wholehearted welcome to all of you in this beautiful winter morning to the inaugural ceremony of 6th International Hepatology Conference organized by Hepatology Society Dhaka, Bangladesh. On behalf of the organizers, we, Dr. Natasha Khurshid and
Dr. Saiful Islam Elin, read you all the highest gratitude.
The theme of this year is Challenges in Hepatology, Exploring the Unmet Needs. Probably, you all know that Hepatology Society has flourished worldwide, but unfortunately Bangladesh remains in darkness. Under the direct supervision and grand auspices of late National Professor Nurul Islam, Professor Mobin Khan, who is better known as the father of hepatology in Bangladesh, started the expedition of hepatology in 1983. From the establishment of the hepatology department in DSMMU, the movement bloomed to form the Association for the Study of the Liver, and finally, in 2009, the Hepatology Society Dhaka, Bangladesh was established to unite the different specialists involved in the management of liver diseases, to create awareness about the liver diseases among the common people, and to develop skilled manpower in the field of hepatology. And from 2010, this scientification took place forward as a biennial International Hepatology Conference that symbolizes this society now. Besides this conference, every year the Society observes World Hepatitis Day and organizes the International NASH Day. Unfortunately, due to COVID pandemic, our sixth conference could not be arranged on time. But we are absolutely happy to arrange it now and grateful to have you with us today. You already know this is a hybrid conference where we will have our inaugural session in presence of our senior leaders and also through Zoom link and our respected guests. The scientific sessions will go on in a hybrid mode. That means the participants will join both physically and through the web link. The foreign speakers will deliver their lectures online, maybe in Zoom. We express our deepest gratitude to have you among us in this long journey. The day-long conference contains 3 scientific sessions with a pair of parallel assemblies in each, following the inaugural ceremony. We cordially invite and hope you will be with us till the end. We are happy enough to announce that we have a number of foreign participants from hepatology and related subjects in this conference and admire that. We thank you from the core of our heart. Today we are delighted to announce that National Professor Dr. Abdul Malik, founder and president of National Heart Foundation of Bangladesh, has kindly consented to grace the occasion as chief guest, but due to some unavoidable situation and as we all understand the present situation and the traffic, he is going to join us through online. We are fascinated to have Professor Muhammad Nazrul Islam, ex-Vice Chancellor BSMMU Dhaka, as our special guest. We gladly announce the names of foremost steersmen of this occasion: Professor Mobin Khan, President of Hepatology Society Dhaka, Bangladesh; Dr. Muhammad Ghulam Mustafa, Treasurer, Hepatology Society Dhaka, Bangladesh; Dr. Muhammad M. Motahar Hussain, Executive Member, Hepatology Society Dhaka, Bangladesh; and Dr. Muhammad Shahinul Alam, General Secretary, Hepatology Society Dhaka, Bangladesh. We have all our honorable guests on the dais, and I also request our ECA members to please join them upon the dais. And ladies and gentlemen, as we have all our distinguished guests and EC members of Hepatology Society on the dais, let us welcome them with a grand applause. Thank you. Now we are going to start our program with a recitation from the Holy Quran. Here I request Hafiz Qari Maulana Mansur Ahmed to please come up on the stage and please recite from the Holy Quran. Maulana Mansur Ahmed. Thank you.
السلام عليكم ورحمة الله وبركاته. أعوذ بالله من الشيطان الرجيم. بسم الله الرحمن الرحيم. يا أيها الذين آمنوا اتقوا الله ولتنظر نفس ما قدمت لغد واتقوا الله إن الله خبير بما تعملون. ولا تكونوا كالذين نسوا الله فأنساهم أنفسهم أولئك هم الفاسقون. لا يستوي أصحاب النار وأصحاب الجنة أصحاب الجنة هم الفائزون. لو أنزلنا هذا القرآن على جبل لرأيته خاشعا متصدعا من خشية الله. وتلك الأمثال نضربها للناس لعلهم يتفكرون. صدق الله العظيم. السلام عليكم ورحمة الله.
Thank you, Mansur Ahmed. Now may I humbly request Dr. Muhammad Shahinul Alam, General Secretary of Hepatology Society, Dhaka, Bangladesh, to deliver the welcome speech for this occasion. Dr. Muhammad Shahinul Alam, please.
Bismillahirrahmanirrahim. Honorable President, Chief Guest in online, Special Guest, the Executive Committee of the Hepatology Society, distinguished participant, ladies and gentlemen, Assalamu alaikum and very good morning. It's an honor and privilege for me to welcome you in this 6th International Hepatology Conference. The Hepatology Society is working for last several years under the charismatic leadership of Professor Mubin Khan, who is the father of the hepatology of the country. This is our biennial conference, which has been delayed for 1 year for the COVID pandemic. You know, the Hepatology Society has established to upgrade the knowledge of the hepatologist and unite the hepatologist and all other clinicians in relation to hepatology in home and abroad. Bangladesh is encountering a changing landscape of liver disease, from communicable disease to non-communicable liver disease. We are consisting of 40 million fatty liver disease and 10 million of hepatitis B and hepatitis C patients. Our projected in 2040, the commonest cause for liver transplantation will be the NASH cirrhosis. To encountering the huge burden of liver disease, we shall have to prepare. The elimination of hepatitis B and C is in the right track as following the sustained development goal. But for a long time, fatty liver disease has long been neglected in addressing clinically and in the management. So huge burden of liver disease should be encountered by producing the huge number of specialists. At least 1,000 liver specialists is needed for the country. And at least one liver institute is needed for the country. Liver transplantation should be immediately started to encounter the end-stage liver disease. The Hepatology Society established to unite the specialists involved in the management of liver disease. By this time, we are continuing our effort to improve our knowledge, upgrade the knowledge and clinical skill and awareness of the patient. We are running the Free Friday Liver Clinic and regularly arranging the scientific meeting, and we are supervising the training and upgrading the training of the hepatologists. By this time, we have trained the APC for the hepatologist and supervising the ERCP training for the hepatologist. And for the awareness of the patient, we have observed the International NASH Day from the very beginning. By this time, we have published diet and fatty liver book for the patient. And we have been working with the APASL and ACLF Research Consortium. Our research is regularly published in internationally indexed journal. For the patient benefit, during the last year, we have published the guidance for Ramadan and liver disease, COVID-19 vaccination and liver disease, and anti-HBC total management clinical practice guideline management. The best one, we think that we had prepared and published a clinical practice guidance of metabolic associated fatty liver disease for the primary care physician. We have trained more than 500 primary care physicians for the management of fatty liver disease from home and abroad. We think that in continuation of our activities, this biennial conference is our highest efficiency to be explored for the clinician. This program is always interested by and participated by the clinician from our country. This time, for the COVID pandemic, we have arranged a hybrid conference, mostly the virtual. You know that this year we had the registration of highest in last year's 1,800 registered participants for our conference. Some of them from our country and some of them from abroad. 13 liver specialists from the abroad who are the leaders of the hepatology will deliver the lecture. I hope that at the end of the day, all the participants, by exchanging their knowledge with the speakers, it will be helpful for us and ultimately will help the patient for the clinical management. Thank you all. Allah Hafiz.
Thank you, Dr. Shahinul Alam. Respected audience, before we move forward, may I request you to please keep your mobile phones in silent mode. আমি সকলের প্রতি বিনীত অনুরোধ জানাবো আমরা আমাদের মোবাইল ফোনগুলো নীরব মোডে রাখি। Now may I request Dr. Mohammad Ghulam Azam, Secretary of Scientific Affairs, Hepatology Society, Dhaka, Bangladesh, to please express the condolence for our beloved late Dr. Khurshid Alam. Dr. Azam, please.
Projection. Assalamu alaikum. Very good morning, learned participants, and today's President, Father of Hepatology, Professor Mobin Khan sir, and our special guest, Professor Nazrul Islam sir, ex-VC, BSMMU, and my society colleagues and all distinguished participants. I welcome you to a condolence speech. This speech is specially dedicated to our late Professor A.K.M. Khurshid Alam sir. And before that, I must take the opportunity to also announce another name, who is late National Professor Nurul Islam sir. Professor Nurul Islam sir, you know him very well. And he, under his direct supervision and grand auspices, Professor Mobin Khan sir started hepatology journey in Bangladesh in 1983. And I'm telling out some words about our Professor Khurshid Alam sir. Professor Khurshid Alam sir was born in Raipura, Norsingdi, from a distinguished Muslim family. And he has a very brilliant academic career starting from his student life, early student life. And he passed MBBS from Dhaka Medical College and was given the Chancellor's Award for securing the first position in the examination. Subsequently, he obtained FCPS in medicine and also got training on medical education from Chicago University, USA, and WHO Fellowship in Gastroenterology from Singapore General Hospital. He was awarded a FRCP from Royal College of Physicians, Edinburgh, UK in 2005. He joined IPGMR as Assistant Professor of Gastroenterology. And when Professor Mobin Khan sir started hepatology in 1983, he joined that department as an assistant professor, and subsequently he became associate professor and also the chairman of that department after retirement of Professor Mobin Khan sir. And he worked as chairman, and he died in working state in that position. He was one of the leading hepatologists and gastroenterologists of the country. He was the founder vice president of our society. He was an astute clinician, a great gifted teacher, a frontline clinical researcher, an educationist, and above all, an altruistic social worker. May we pray for this departed soul. May Allah subhanahu wa ta'ala grant him Jannah. Thank you very much. Assalamu alaikum.
Thank you, Dr. Azam. Now, may I humbly request Dr. Ghulam Mustafa, Treasurer of Hepatology Society, Dhaka, Bangladesh, to please introduce today's distinguished speakers of this auspicious conference. Dr. Muhammad Ghulam Mustafa, please.
What's that? Respected President of the inaugural session of the 6th International Hepatology Conference 2021, Professor Mobin Khan, President, Hepatology Society, Dhaka, Bangladesh. Honorable Chief Guest online, National Professor, Retired Brigadier Dr. Abdul Malik, Founder and President of National Heart Foundation of Bangladesh. Honorable Special Guest, Professor Muhammad Nazrul Islam, ex-Vice Chancellor, Bangabandhu Sheikh Mujib Medical University, Dhaka. Dr. M. Muthar Hussain, Executive Member, Hepatology Society, Dhaka, Bangladesh. Professor Dr. Muhammad Shahinun Alam, General Secretary, Hepatology Society, Dhaka, Bangladesh. Dr. Muhammad Ghulam Azam, Scientific Secretary, and all the members of the Executive Committee of Hepatology Society, Dhaka, Bangladesh. Distinguished speakers from home and abroad, participants, sponsors, media personnel, ladies and gentlemen, a very good morning. It's a great pleasure for me to introduce to you the distinguished guest speakers of the 6th International Hepatology Conference 2021. A list of indebted speakers of 6th International Hepatology Conference 2021. Professor Ed Gain from New Zealand, Professor Jacob George from Australia, Professor Chering Chung from Hong Kong, Professor Kelvin Casey NG from Hong Kong, Professor Jialong Qi from China, Professor Taosek Tanawandi from Thailand, Professor M.R. Fitzpatrick from Ireland, Dr. P.N. Audrey from France, Dr. Professor Anna Suk Fong Luk from USA, Professor Piyaporn Epicentronok from Thailand, Professor Mahesh Kumar Goenka from India, Professor Julia Wendon from United Kingdom, and lastly, Professor Francis Doran from France. Our heartiest welcome to all the guest speakers to Bangladeshi conference. First of all, Professor Ed Gain. Gain is a professor of medicine at the University of Auckland, New Zealand. He is a hepatologist and deputy director of the New Zealand Liver Unit at Auckland City Hospital. Next is Professor Jacob George. He is the head of the Department of Gastroenterology and Hepatology at Westmead Hospital and Director of Gastroenterology and Hepatology Services for the Western Sydney Local Health District. He is a founding member of the Asia Pacific Regional Advisory Council to the American Association for the Study of the Liver. And next, Dr. Chering Chung is currently the clinical professional consultant in the Department of Surgery, Prince of Wales Hospital, the Chinese University of Hong Kong. Her main research interests are minimal invasive surgery for hepatobiliary and pancreatic diseases. She serves as the council member of Hong Kong Society of Hepatobiliary and Pancreatic Surgery. Next is Professor Kelvin Casey NG. He is a professor of surgery at the Chinese University of Hong Kong. He specialized in hepatobiliary and pancreatic surgery and liver transplantation. Currently, he is the Chief of Division of Hepatobiliary and Pancreatic Surgery, Department of Surgery, the Chinese University of Hong Kong. Professor Jiao Long Qi is a professor of medicine and founder chairman Chess Portal Hypertension Alliance in China. He is the chairman, Professional Committee of Portal Hypertension. Next is Professor Tausek Tanawandi. He is the hepatologist at the Division of Gastroenterology and Hepatology Faculty of Medicine at Sri Raj Hospital, Mohidul University, Bangkok, Thailand. He is the immediate past president of APIASL and was the past president of Thai Association of Study of the Liver. Professor M.R. Fitzpatrick is the pediatric hepatologist at the National Center for Pediatric Liver Disease, Children's Health, Ireland, and the Pediatric Liver Center, King's College Hospital. She is also an honorary clinical senior lecturer at the King's College Hospital, London, and associate professor at the University College, Dublin. Professor P.N. Audrey is an assistant professor at the Department of Hepatology, Biojon Hospital, Clichy, France. Professor Anna Suk Fong Luk, she graduated from the University of Hong Kong Medical School. She completed her hepatology training in London under Professor Dame Sheila Sherlock. She joined the University of Michigan in 1995 and is currently Director of Hepatology Program and Assistant Dean of Clinical Research. She is an associate editor of two textbooks, Sheila Sherlock's Diseases of the Liver and Biliary System and Yamada textbook of gastroenterology. Professor Piyaporn Epicentronok, she is Professor of Gastrointestinal Radiology, Department of Radiology, Sri Raj Hospital, Mohidul University, Thailand. She has fellowship in abdominal imaging and her area of interest is gastrointestinal radiology. Professor Mahesh Kumar Goenka is the Director and Head, Institute of Gastrosciences and Liver Transplant, Apollo Hospital, Kolkata. Mr. Goenka is the President of Indian Society of Gastroenterology. He is a clinical adjunct professor of medicine at the University of Wisconsin. Professor Julia Wendon is an intensive care consultant and hepatologist at King's College Hospital. She has special interest in liver ICU. And lastly, Professor Francois Durand. He is the head of the Department of Hepatology and Liver Intensive Care Unit of Biojon Hospital, Clichy, and Professor of Hepatology at the University of Paris, France. His main interest in research and teaching are liver transplantation, complication of end-stage liver cirrhosis, and acute liver failure. These are all about our guest speakers. Please enjoy all the sessions and have a very nice day. Stay safe and thank you all.
Thank you, Dr. Mustafa. It's the time to hear something from our respected special guest. So most humbly I request Professor Mohammad Nazrul Islam, ex-Vice Chancellor BSMMU Dhaka, to please deliver his speech. Our special guest, Professor Mohammad Nazrul Islam, sir, please.
Distinguished guests and the renowned hepatologists of the country and the distinguished participants of the conference, honorable chief guest and the chairman of the session, Professor Mobin Khan, a reverend in these subjects in Bangladesh. Assalamu alaikum. I am honored to be invited in the inaugural session of the 6th International Hepatology Conference organized by the Hepatology Society, Dhaka, Bangladesh, under the leadership of Professor Mobin Khan. Hepatology Society has been playing a significant role in developing the hepatology services in Bangladesh. This society organizes International Hepatology Conference biannually. Furthermore, the society takes active part in the campaign to raise awareness about the viral hepatitis, observes World Hepatitis Day every year, arranges roundtable talks on various liver diseases, organizes webinars at the community level physicians. The theme of the 6th International Hepatology Conference is Challenges in Hepatology, Exploring the Unmet Need. The topic to be presented in this conference widely cover the disease conditions which the hepatologists face as challenges in managing the liver disorders worldwide. The renowned hepatologists from abroad will present their lectures virtually due to COVID pandemic and enrich our knowledge in management of these liver disorders. I hope that by their deliberations, the theme of the conference will be achieved. I wish the hybrid conference a success. Thank you.
Thank you very much, dear sir. Now, most respectfully, I would like to request our chief guest, National Professor Retired Brigadier Abdul Malik, founder and president of National Heart Foundation, to say something on this propitious moment. And as I mentioned earlier, he has joined us online. So, dear sir, it's your time to say something in this occasion. Our chief guest online. Thank you, sir.
Bismillahirrahmanirrahim. Professor Mobin Khan, Professor Nazrul Islam, special guest, member of Executive Council of Hepatology Society of Bangladesh, respected faculties from home and abroad, participants, Assalamu alaikum. I am very delighted for the invitation in the 6th International Hepatology Conference arranged by Hepatology Society of Bangladesh. Bangladesh has made progress in health sector in different specialties. When Bangladesh was born in 1971, at that time there was no specialty. Everything, every medical side or surgical side mostly was seen or arranged and looked after by a general physician or a surgeon. But by these years, many specialties has come up, and hepatology one of them. For this, I congratulate and thank Professor Mobin Khan, who is a senior most hepatologist in the country, and for his contribution for development of the advancement in the hepatology field. It takes time to develop everything, and liver is a very vital organ in the body. And this can be affected by communicable or non-communicable diseases. And nowadays, particularly in Bangladesh and Asian countries, non-alcoholic fatty liver is becoming a problem. So anyway, this problem, infectious or non-infectious, it is a problem, and we will have to tackle it. And this tackling is not very easy, because we are 170 million people. We need more specialists. The number of specialists in every field is very much limited. So we will have to create more manpower. It's very important. For this, I am sure that Hepatological Society is trying, and they should try to improve the expert manpower. And we must remember that creation of manpower takes time, and you have to acquire knowledge, both theoretical and practical, and those who are coming in the field, they must be very sincere. Because without sincerity of purpose, you cannot shine. World has become a global village. There is always competition in the national and international field. So I am sure you are trying, and continue it. It will take time. We have the development power for our people, and also create awareness among the people. This is very important. For this reason, the non-communicable disease, particularly heart, cancer, diabetes, and liver diseases, kidney diseases, are a big problem. Once it comes, it becomes chronic, and life becomes miserable. And if you want to attain economic prosperity and sustain it, that is sustainable development goal achievement and retention, is not very easy. We'll have to keep our people healthy and active, because if they get a liver disease or heart disease or diabetes, then it becomes chronic, and they become economic burden to family, society, and the country. So anyway, you are trying, and you should continue it. Effort should be there, and create awareness, create more power. And I will tell younger participants, you should learn, because you have heard that the distinguished speaker from abroad who have joined online, they are very useful. You must try to learn from them and try to help us. Please remember that knowledge is important, action is also important, and you should think and work with sincerity of purpose, ethically, and also keeping your moral high. Because in our country particularly, our country, many are poor people, they do not know, they are ignorant, they do not know many things. So after treatment, when whoever comes to you, see them and advise them sympathetically and try to go. Because our life is very short in eternity. So whatever you do, somebody will become doctor, somebody engineer, but our work should be done sincerity, learn it, do it properly, then success will be yours. Please remember success and failure of life for anybody depends on his own activity. If you work sincerely, the success will be yours. And if you work half-heartedly, it will not be easy. So I thank the organizer and Professor Momin Khan for inviting me in this important inaugural session. So I hope this will be very useful. Try to learn, try to do good to people, and do your job properly. Allah will be with us. Thank you very much for inviting me. Thank you very much. Wish you success. Wish you success. Thank
Thank you
you.
very much, sir, for your inspirational speech, and hope we will have you connected throughout the conference. Now, most humbly, I would like to request Professor Mobin Khan, President of Hepatology Society, Dhaka, Bangladesh, to please deliver his speech. Dear Professor Mobin Khan.
Bismillah ar-Rahman ar-Rahim. On behalf of the organizing committee, it is my great pleasure and honor to welcome you all to this inaugural session of the 6th International Hepatology Conference. I express my heartiest gratitude and thanks to our honorable chief guest, National Professor Brigadier Retired Dr. Abdul Malik, founder and president of National Heart Foundation, Bangladesh. We are delighted to have amongst us as special guest Dr. Professor Muhammad Nazrul Islam, pioneer biologist of Bangladesh and Vice Chancellor, Bangabandhu Sheikh Mujib Medical University. Respected teachers, speakers, guests, participants, members of the electronic and print media, and dear audience. Hepatology Society Bangladesh has been working tirelessly on raising awareness about liver disease among the mass population with an aim to increase preventive measures, to update knowledge of the physicians engaged in the management of liver diseases, to improve treatment success, and to strive towards the development of the treatment guidelines and facilities in the context of the country to ensure the availability of the latest management. In line with that endeavor, the Society organizes 2 yearly international conferences and invites distinguished hepatologists, scientists, and physicians from around the world to gain knowledge about the latest developments in the prevention, diagnosis, and management of various liver diseases. Due to the post-pandemic situation of the world, we have adopted a hybrid conference to continue our venture this year. Human population is now facing a considerable burden of fatty liver disease and genetic diseases. These diseases occur irrespective of socioeconomic and ethnic differences of the people around the world. However, a great breakthrough has occurred in the perception and knowledge of mechanisms behind these diseases in recent years. Hence, specific and advanced management of these entities might not be far away. However, tremendous advances have been taken place in the management of other liver diseases over the last decade. Both medical and surgical treatment options have achieved a high standard throughout the years. Treatment of hepatitis C associated chronic liver disease and cirrhosis is now more streamlined and compact, with treatment choices narrowed down to especially 4 directly acting antivirals. The treatment now constitutes 2 pan-genotypic simplified regimes of dual drugs, including combination of gracipravir, pibrentamab, or sabuzabir, belpartasvir. This is because of the advance of knowledge of human on the research plan of seafarers has achieved the highest goal. These regimes have considerably reduced the duration of treatment and remarkable success in the sustained biological response. We are hopeful that seafarers will be eliminated from the world very soon. A 7 to 10% weight loss with structured moderate intensity exercise is now the first line recommendation for the treatment of NAFIL and NAS. While newer pharmacological agents for unhealthy like obeticholic acid are on phase 3 clinical trials. Also, recent developments include laparoscopic liver resection, 4 localized tumors, and endoscopic bariatric and metabolic therapies for fatty liver disease and metabolic syndromes. Prevention of portal hypertension, hypertensive bleeding includes management of medium and large varices with non-selective beta blockers. While acute variceal bleeding requires management with vasoactive agents, antibiotics, and endoscopic variceal ligation when the bleeding stops. Early and prompt delivery remains the mainstay of treatment for most of the liver diseases unique in pregnancy. Tropical infectious agents frequently invade the liver and their treatment requires management of the underlying infection. Today's day-long virtual conference, world-renowned clinicians and scientists will update us on various latest developments in liver disease management. Let us enrich our knowledge from these deliberations. We are indebted to our sponsors for their kind support in organizing this conference. We request our friends from print and electronic media to increase awareness among general people about the prevention of liver disease. I sincerely hope for your gracious presence and active participation in all scientific sessions. Allah Hafiz.
Thank you so much, sir, for your valuable speech. Lastly, may I humbly request Dr. M. Mothar Hussain, Executive Member of Hepatology Society, Dhaka, Bangladesh, to please deliver the vote of thanks. Dr. M. Mothar Hussain, please.
Honorable Chief Guest online, National Professor Brigadier Abdul Malik, respected special guest Professor Nazrul Islam, ex-Vice Chancellor, BSMMU, Professor Mobin Khan, President of Hepatology Society, Dhaka, Bangladesh, our most valued invited guests, participants, ladies and gentlemen, Assalamu alaikum and a very good morning. It's a great honor for me to get the opportunity to thank you all dignitaries. On behalf of the Hepatology Society, Dhaka, Bangladesh, I extend a warm welcome to all the people around the world who have joined with us today for the 6th International Hepatology Conference, Dhaka 2021. I'd like to express my gratitude to all esteemed delegates of the conference for their presence and contribution to make this endeavor of ours a great success. Our guest speakers have made a tremendous effort to share their experiences and research findings with our participants. We are indeed very grateful to all of you. I extend my gratitude to our Honorable Chief Guest, National Professor Brigadier Abdul Malik, retired, to take out time from his busy schedule to grace the event. Thank you for inspiring and encouraging us with your words on this special day. A special thank to our special guest, Professor Muhammad Nazrul Islam, who has been a staunch supporter of our society since its inception. I must mention our deep sense of appreciation for all the participants of this conference for taking trouble to register and participate and making this conference a success. I must sincerely thank the members of the organizing committee and the members of the Hepatology Society Dhaka, Bangladesh in general, as well as all the volunteers for working hard for the past few months with exceptional zeal and enthusiasm. We are also grateful to all the sponsors for their generous contributions towards organizing this conference. I express our gratitude to the journalists, photojournalists, and other members of the print and electronic media for giving an excellent coverage of our conference. I appreciate the management of the Pan Pacific Sonargaon Hotel, Dhaka, for their excellent cooperation in the organization of this event. I hope that the conference will be noteworthy and memorable to all. Thank you very much. Allah Hafiz.
Thank you so much, and thank you, ladies and gentlemen. Here we conclude the inaugural session of today's symposium. But before we move forward for our scientific session, may I request all of the members of the Hepatology Society Dhaka, Bangladesh to join our distinguished guest on the dais and the EC members of the Hepatology Society Dhaka, Bangladesh to have a group photo. And I also request our photographers to take the pictures. All the members, please join us for a group photo. আমরা একটা গ্রুপ ছবি নেবার জন্য সকলকে বিনীত অনুরোধ করছি যারা সাধারণ সদস্য রয়েছেন হেপাটোলজি সোসাইটি ঢাকা বাংলাদেশের তারা দয়া করে মঞ্চে উপবিষ্ট আমাদের আজকের অতিথিবৃন্দ এবং ইসি মেম্বারসদের সঙ্গে যোগ দেবেন আমরা একটা ছবি তুলতে চাই আমরা আমাদের বৈজ্ঞানিক অধিবেশনগুলো শুরু করার আগে একটা গ্রুপ ফটো নিতে চাইছি এবং আশা করছি আমাদের বৈজ্ঞানিক অধিবেশন ঠিক 12টায় শুরু হবে যেমনটি আমরা শিডিউল করেছিলাম যদিও আমাদের মঞ্চ উপবিষ্ট যারা আছেন অনেকেরই মুখ মাস্কে ঢাকা তারপরে আমরা বলবো মুহূর্তটি স্মরণীয় করে রাখতে আমরা একটু হাসি হাসি মুখ করি সবাই বেশ গম্ভীর ধন্যবাদ এই প্যান্ডেমিকের পর আমরা যে এক বছর পর হলেও সবাই একত্রিত হতে পেরেছি সেজন্য সবাইকে অসংখ্য ধন্যবাদ যারা সময় দিচ্ছেন সো আমরা একটা জোর করতালি দিতেই পারি নিজেরা নিজেদের জন্য thank you all we shall move on to our scientific session with two simultaneous sittings at sharp 12 noon you know the theme of the conference for this year is challenges in hepatology exploring the unmet needs. One session will be held here at Grand Ballroom A. The topics are pre-cirrhotic portal hypertension syndrome and tropical liver diseases. Another in Grand Ballroom Hall B, and the topic will be pediatric liver diseases, current challenges and future perspective, and another one is management of liver diseases in pregnancy and update. So I would like to request our guests to choose the session according to their interests. সম্মানিত অতিথিবৃন্দ, আমরা ঠিক 12টায় আমাদের বৈজ্ঞানিক অধিবেশন সায়েন্টিফিক সেশন শুরু করব, যেটা প্যারালালি দুটো ঘরে হবে, গ্র্যান্ড বলরুম এতে এবং গ্র্যান্ড বলরুম বিতে। আপনারা আপনাদের পছন্দ অনুযায়ী সেশনগুলো বেছে নিতে পারেন এবং আশা করব আপনারা সেভাবেই আমাদের সঙ্গে যুক্ত থাকবেন। সবাইকে ধন্যবাদ। আমরা ঠিক 12টায় আমাদের সায়েন্টিফিক সেশন শুরু করব। দেখছি। ও আচ্ছা। ও, অসুবিধা নেই। Okay. Ladies and gentlemen, I have an announcement for Grand Ballroom Hall A. I have mistaken that the first session is on hepatitis C, management in general and special population, metabolic dysfunction associated fatty liver disease and metabolic steatohepatitis, diagnosis, treatment and monitoring. These are the topics for Hall A. And for Hall B, liver resection, which patients are benefited more, and cholangiocarcinoma, management update, surgery or intervention. জি স্যার, এটা হল এ, হেপাটাইটিস সি। জি জি জি। থ্যাংক ইউ স্যার। স্যার না, না স্যার, সব কিছু অনলাইনে। এখনো পড়ি, মাঝে বন্ধ ছিল। আই এম ক্যান্সার সার্ভাইভার, সো মাঝে অনেক দিন অফ ছিল। এখন কেমোথেরাপি চলছে, ওরাল কেমোথেরাপি, ম্যাস্টেক্টমি করা হয়েছে। জি স্যার, সবাই এটা করতেই আগ্রহ প্রকাশ করলো। খাদ্য সম্মানিত অতিথিবৃন্দ, যারা গ্র্যান্ড বলরুম এতে সেশন শুনতে আগ্রহী তাদের বিনীত অনুরোধ জানাচ্ছি এই রুমে চলে এসে আসন গ্রহণ করতে। আমরা অল্প কিছুক্ষণের মধ্যে আমাদের সায়েন্টিফিক সেশন শুরু করব। আমাদের স্পিকাররা রয়েছেন এবং চেয়ারপারসনরাও চলে এসেছেন। Learned audience, ladies and gentlemen, I am Dr. Natasha here welcoming you to the first scientific session in Ballroom A. The session is on hepatitis C management in general and special population and NASH diagnosis, treatment and monitoring. Chairpersons of these sessions are Professor ex-Brigadier General S.K. Mohammad Bahar Hussain and Dr. Mohammad Firoz Amin. The speakers are Professor Ed Gain from New Zealand and Professor Jacob George from Australia. Honorable chairpersons and the speakers are already with us. Here I would like to request the rapporteur, Dr. S.K.M. Najmul Hassan, to please take over the microphone and conduct the session. Dr. S.K.M. Najmul Hassan, please. I am requesting Dr. Najmul Hassan to please start the session. Here we have our rapporteur, Dr. S.K.M. Najmul Hassan, to proceed the session.
Dear participant, Assalamu alaikum and welcome you all to today's 6th International Hepatology Conference organized by Hepatology Society, Dhaka, Bangladesh. I am Dr. S.K.M. Najmul Hassan and will be present throughout the session as rapporteur. This session will be chaired by Professor Brigadier General Retired Sheikh Mohammad Bahar Hussain and Professor Mohammad Firoz Amin. First of all, I would like to request the chairperson to come to the dais and take their seat. In this session, two eminent speakers from abroad will deliver their speech and we are waiting eagerly to hear from them. First of all, I would like to request Professor Brigadier General Retired Sheikh Mohammad Bahar Hussain sir to introduce the first speaker and conduct the session. Thank you once again.
Assalamu alaikum. Good afternoon, everybody. After a very long time, we have gathered again for the scientific sessions. So, a special thanks to the Hepatology Society for introducing this scientific sessions. I think we have met after about 2 years. So today, the session is hybrid sessions. We have online speakers. Our first speaker will speak on the hepatitis C, that is hepatitis C management in general and in special. He is Professor Ed Gain. He is a professor of medicine in University of Auckland, Australia, New Zealand. He is hepatologist and deputy director of the New Zealand liver units at Auckland City Hospital in New Zealand. Dr. Gain chairs the Ministry of Health Committee responsible for the hepatitis C elimination and co-writer of the first New Zealand National Hepatitis C Action Plan. So I think with these few remarks, we can start our first speech, and that will be online. So.
And I hope to get there as soon as we're allowed. I'll just share my screen. You need to allow me to share my screen. So organizers, if you could let me share my screen. Thank you. I'll have to try again. Okay, I'll just try again to share my screen, please. Excuse me. We're having some problems here, which hopefully we will. Can you see my screen? All right. Now, can you see my slides? Yes? Hello? Okay. Today, I'm going to talk to you about an update on hepatitis C. These are my disclosures. Can you just confirm that you can see my slides?
Sir,
Please?
sir. Yes, sir. It's clear, sir.
Thank you very much. I'll carry on. The global mortality from infectious diseases is changing rapidly. Thanks to improvements in public health, we've seen a rapid drop-off in mortality from HIV, tuberculosis, and malaria worldwide. But at the same time, we've seen an increase in people dying from viral hepatitis. And by 2040, more people will die from hepatitis B and C than from HIV, malaria, and tuberculosis combined. Currently, we think around 71 million people are living with hepatitis C, and over half of those live in the Asia-Pacific region. And I've given the approximate numbers here of between 0.88 and between 3 and 9 million people in Bangladesh are living with chronic hepatitis C. If we look at some of the epidemiology we have from your country, the earlier studies showed a very high prevalence rate of 5.6%. This was a healthy population within Dhaka. It included a lot of day laborers, and as you know, the infection rate is much higher in them. And in this early study of 1997, the predominant genotype was genotype 1b. In a later study, less than 1% of blood donors were hepatitis C positive. And most of the blood donors were associated with the recognized risk factors of traditional health practice, mass vaccination, or hair cutting by barbers. I should point out the most recent study published 2 years ago in people who inject drugs in central Dhaka. Here it showed that rates of hepatitis C were the same as they are in injecting drug users throughout the world. Around 35% were RNA positive. But note the change in genotype, and this is a worldwide phenomenon. In people who inject drugs, the predominant genotype is now genotype 3. The first global health sector strategy from the World Health Organization in 2015 said that we should be able to eliminate hepatitis C in every country in the world now that we have new therapy. And these were the initial goals, what we call the impact goals from the World Health Organization. An 80% reduction in incidence of new cases and a 65% of reduction in death. And these were the targets most countries were aiming for. However, this year, the World Health Organization released a new document which said we should be more important in first of all, diagnosing people with hepatitis C, so finding those who are undiagnosed, and linking them with treatment. 90% diagnosis rate, 80% treatment rate by 2030. These are really ambitious goals. And worldwide, we're not doing that well. This is a cascade of care broken up by WHO regions. But suffice to say, there's a huge difference in infection and diagnosis and treatment. And we're still around 3/4 of those infected are not diagnosed. And we are getting nowhere near the targets on our current trends. And similarly, for people who are diagnosed starting on treatment. And we know that these gaps are even higher in low-income countries. So what can we do to eliminate hepatitis C? Well, the 3 caveats for this are simplifying treatment, and that's really what I want to talk about. I'll mention how we can find the undiagnosed and improve linkage to care, but we really need to simplify treatment and take it to the community. We've had a huge improvement in success of treatment with development of the DAAs, the direct-acting antivirals, from interferon days to the first DAAs with interferon to the first all-oral treatments of Vicarapac, Zepatier, and Harvoni. And these were the ones which were available for our use in 2016. But these are just not good enough. They're too complicated to use in the community because you need different doses, different durations for different genotypes, different viremia levels, patients with resistance at baseline, and all these disease factors, previous treatment factors, and whether or not someone has comorbidities. And most of these early DAA regimens had lots of drug-drug interactions. But we've made a huge jump since 2016, and this is the development of the pan-genotypic treatments. Eclusa or soft valve, Mavorite or glecaprevir preventosvir. And you can see that's increased the cure rate to almost 100%, but it's also reduced the duration to 12 and 8 weeks. And these are the treatments where we will be able to eliminate hepatitis C. If we look at the results for sofosbuvir velpatasvir in treatment all genotypes of hepatitis C, this is a combination of all the Gilead studies. You can see across the genotypes, the cure rates are extremely high. And overall, the cure rate is 98%. Because of these studies, in June 2016, sofosbuvir velpatasvir, known as Eclusa, was approved for treatment of all treatment-naive patients for 12 weeks. So one size fits all. What about glecaprevir preventosvir? Again, looking at treatment-naive patients of all genotypes. If you put together 10 different studies of over 2,000 non-cirrhotic patients, you can see that the cure rates in patients without cirrhosis with 8 weeks of glecaprevir preventosvir is very, very high, and overall 99% cure rate. If you looked at cirrhotics, at 308 cirrhotics, where they in these initial studies used 12 weeks, because they thought cirrhotics would be more difficult to treat, they found that with 12 weeks of glecaprevir preventosvir, 97% of patients were cured. So in 2017, 8 weeks of Mavorite was approved for non-cirrhotics and 12 weeks for cirrhotics. But they thought that these results were very high, so they went on to look at 8 weeks of glecaprevir preventosvir in cirrhotics. And this was what we call the Expedition 8 study. And this confirmed that 8 weeks was all you needed for cirrhotic patients as well. And this is modified intention to treat, so everyone who took their tablets, 99.7% of cirrhotics were cured. So based on this very excellent result, from 2020, 8 weeks of glecaprevir preventosvir is the recommended treatment both in non-cirrhotics and in cirrhotics. One size fits all. And this is the latest EASL guidelines and the ARSL guidelines are the same. So this is for treatment-naive patients, regardless of genotype, regardless of cirrhosis present or not, 12 weeks of soft valve for everyone, or 8 weeks of glecaprevir preventosvir for everyone. This is very simple treatment, and it makes it easy for people to prescribe outside the hospitals. We have seen, thankfully, for many countries such as Bangladesh and Pakistan and India, the availability of licensed generics. First, the Gilead generics of ledemsivir, sofosbuvir velpatasvir, and more lately the AbbVie generic of glecaprevir preventosvir. And I'm told that these are the drugs you have currently available in Bangladesh. with glecaprevir, preventosvir, and sofosbuvir, valpatisvir as the two pan-genotypic medications. These simplified treatments have increased moving treatment from the hospital to the community. This is what has happened in New Zealand. In New Zealand, we only have glecaprevir, preventosvir available for patients. And you can see that since it's become available, we've shifted from everyone being treated in the hospital to almost everyone being treated in the community. And this is by GPs or family doctors, but also by other community settings, which I'll come to. So these new pan-genotypic treatments, where you give the same regimen to everyone, makes it very easy to treat people in the community. We looked at everyone who's been treated in the community and everyone who's been treated in the hospital, and the cure rates are exactly the same. And this is the beauty of these new, highly potent pan-genotypic regimens of Sofval and glecaprevir, preventosvir. So we have the simple treatment. Now we have to find people to treat them. How do we find the undiagnosed? Around the world, I said, around 75% of people living with Hep C do not know they have it. So how do we find the undiagnosed? Well, the current testing in most countries is by risk factors. Do you have a risk factor for hepatitis C? And here I've listed the risk factors we have used in our national promotion in New Zealand, which is, have you injected drugs? Have you been in prison? Have you had tattooing or body piercing? Have you had a blood transfusion? Have you ever been jaundiced? Have you received medical treatment in countries with a high prevalence? Or did your mother have hepatitis C? This is what we call targeted testing. But we know that from some very good studies in the Netherlands and Sweden, and that if you use these risk factors to pick up people with hepatitis C, you still miss 40% of people. And that's because of the stigma associated with hepatitis C and catching hepatitis C through drug use. But it's also the stigma just of having the infection. So the best way to get around that stigma is to test everyone. And this is cost effective if you have a national registry, so you know who's been tested before. These are the countries where universal testing have been implemented. In France, it's been going for 5 years, and they are the country to first eliminate hepatitis C. The most recent country who brought this in earlier this year is Italy. Every adult will be tested for hepatitis C. But the big change happened in America when the CDC recommended that every adult is now tested for hepatitis C. If you test everyone who's an adult, you will find every case, and it's simple to treat with the new treatments. You can eliminate hepatitis C in that country. Finally, what about eliminating hepatitis C by improving linkage to care? You have a wonderful new treatment, which is easy to use. You have a way to test everyone, but once you've tested them, you need to make sure that they come and get treated. And that can sometimes be very difficult. We are trying to simplify the hepatitis C pathway in New Zealand and in many other countries. We're using new testing, which can be done in the community. We're doing reflex testing for antigen. We're now doing dry blood spot testing, where the person does a pinprick and we send the blood to the lab. We're also doing point-of-care antibody tests and the new point-of-care RNA tests. These are the gene expert tests, which have become so common with the COVID pandemic. So we're using more and more point-of-care tests in the community to make the diagnosis. So we're taking the testing to the patient. And then we're simplifying assessment. We no longer have to do genotyping with Sofval or glecaprevir, preventosvir. We don't have to do biopsies. We don't even have to do FibroScan. We use the APRI score. And the APRI score, if it's less than 1, then we know that that person does not have cirrhosis. If it's greater than 1, then we do a FibroScan. And that has sped up the linkage to treatment from the time the person has the test. So we're simplifying the pathway to treatment. We have a couple of novel programs we've just introduced in New Zealand to try and offer treatment to everyone in the community. We've taken on the Scottish approach. Scotland moved treatment from the GPs and the doctors into the pharmacies. So in Scotland, the community pharmacies offer testing and treatment, and we are now doing that in New Zealand. So you go to the pharmacy, you have a finger prick test. If your finger prick is positive, you have a venipuncture which goes to the laboratory, you come back and you get started by treatment in the pharmacy by the pharmacist. And we find this is very useful for people who will not go to a doctor, who can't afford to go to a doctor. This is provided free. We also have a new initiatives in our most highest risk populations. These are people who inject drugs, including people who go to the needle exchange and sex workers. And we have test and treat programs based at the clinics. They have the finger prick test, not for the antibody, but for the RNA, and they start treatment the same day. So they get tested and put on treatment that same day. And we find that is very successful in linking people to treatment so they are not lost to follow-up. But what happened in 2020? We knew we got the COVID pandemic. And I realized how much impact that has had in your own country with such a high infection and mortality rate. I hope it is coming under control. It's had a major effect around the world on hepatitis C elimination. It stopped people accessing hepatitis C services across the board. It's deprioritized hepatitis C screening programs and linkage to treatment. And our nurses and doctors who were working with hepatitis C have now been reallocated to work with COVID testing, vaccination, and now treatment. This paper earlier this year from the CDC, this is Homi Razavi, shows that over the last year, the COVID pandemic has had a dramatic impact on hepatitis C elimination. Because people haven't been going to harm reduction, there's been more infections, almost 2/3 of a million infections, which otherwise would not have happened. There's been almost 100,000 deaths, which would have otherwise not happened. There have been almost 50,000 cases of liver cancer, which should not have happened. This is all due to the pandemic. We're starting to look, though, at the opportunities the pandemic have provided us for hepatitis C elimination. I think there's no doubt that the general population has become aware of infectious diseases and the possibility of eliminating them. We are all using telemedicine. Across the world, we are helping people in the field work up and treat their patients. We're using accelerated pathways, as I've shown you. We're moving treatment out to where the patients are. We have just introduced a combined hepatitis C COVID-19 screening, and we're doing across our vaccination programs, we're offering hepatitis C testing. And we're finally using simpler treatment. So we've learned many things from COVID which are helping us. And certainly the point of care testing for COVID has been transferred to hepatitis C. So to finish the first part of this talk, for hepatitis C in the general population, the antiviral treatments you have, soft valve, are simple. They're perfect for community prescribing. There's once daily dosing. There's no need for ribavirin. There are no real side effects. The drug-drug interactions are rare. We don't need to monitor people on treatment, and the cure rates are higher than we could ever have imagined. The only remaining barriers to treatment are what I've said: lack of awareness, low diagnosis rates, and poor linkage to care. But I would emphasize the lessons we're learning from the COVID-19 pandemic with point-of-care testing are going to be very important for increasing hepatitis C elimination efforts. I'm going to now turn to treating hepatitis C in special populations. And I'll start off with treating people on dialysis or people with end-stage kidney disease. We know that hepatitis C is very common in people on dialysis, in particular in India, Pakistan, and Bangladesh. And there are many risk factors for that. So I know that you have high rates of hepatitis C in your dialysis population, although it is now falling. And we know that hepatitis C reduces survival in people on dialysis. Their risk of death increases by 1.6-fold. It's very important that we reduce the risk of death by treating the hepatitis C. And the NET study showed that. In this worldwide study, they showed with propensity matching that if you treated someone with hepatitis C, you reduce their risk of death by over 50%. And this was the old pegylate interferon, which had a very low uptake. Less than 1% of people living with hepatitis C on dialysis were actually started on hepatitis C. But what about our wonderful new treatments? Well, what treatments can we use in renal failure? These are all fine because they're all metabolized by the liver. The nukes are not. So sofosbuvir and ribavirin are not metabolized by the liver. They're cleared by the kidney. So in kidney failure, you get enormous increases in exposure to these drugs. Can you use them? I'll come to that in a minute. But really, our treatment of choice now in treating patients with renal failure is the new treatment of dacapavir preventosvir. This is the Expedition 4 study, which I presented and published. We treated over 100 patients. Most of them were on dialysis. Many were cirrhotic or interferon failures. We treated them with 12 weeks of Mavorite. And the cure rate was phenomenal. We had an SVR rate of 98%, and the only patient who wasn't cured actually died of an unrelated cause during treatment. So the modified intention treatment was 100% were cured. This was incredibly safe. There were no treatment-related adverse events or serious adverse events, and no treatment-related laboratory abnormalities. So Mavorite or dacapavir preventosvir is the treatment of choice now in patients on dialysis. And this is the real-world study of over 120 patients, and the real world showed the same very high cure rates. And 8 weeks is as good as 10, 12 weeks. So now the recommendation is only 8 weeks of Mavorite is needed in patients on dialysis. What about sofosbuvir? Many countries in the world have generic sofosbuvir, but we're worried that you couldn't use it because it was cleared by the kidney. And because the sofosbuvir is eliminated in the urine, the major metabolite, if you don't have any kidney excretion on dialysis, you get a marked increase in exposure of sofosbuvir and its main metabolite. And the recommendations were we should only use sofosbuvir containing regimens if the GFR was greater than 30. But plenty of real-world experience showed no problems. So I was involved in an FDA-requested study with Gilead looking at people with renal failure. It was a long study. We did 3 separate arms of the study, increasing the dose of sofosbuvir and then adding ladipasvir. And what we showed was, as expected, we got an increase in sofosbuvir in the plasma, got an increase of its major metabolite in the plasma, but there was no effect in ladipasvir. Ladipasvir is metabolized not by the kidney, it's not cleared by the kidney, so the only increase in exposure was in sofosbuvir and its metabolite. But there was no toxicity. And there was an increase in cure rate. If you looked at sofosbuvir and ladipasvir, in genotype 1 patients, all of them were cured with 12 weeks of sofosbuvir and ladipasvir. All the adverse events were due to ribavirin toxicity. So when you took away the ribavirin, when you used sofosbuvir and ladipasvir, you had 100% cure, no toxicity. And really, this suggested that sofosbuvir exposure goes up, but there's no toxicity. And since then, there's been a study of sofosbuvir valproatovir by Gilead in all genotypes, showing that, again, it was safe and highly effective. 98% of people were cured, regardless of genotype, patients on dialysis, and there were no treatment-related AEs or SAEs. So this tells us that we can use sofosbuvir regimens in people on dialysis. And the large real-world experience across Europe has confirmed this. That sofosbuvir valproatovir, sofosbuvir ladipasvir, sofosbuvir decladisvir is safe and highly effective in patients on dialysis. So in the real world, we can use sofosbuvir regimens in patients with chronic kidney disease. What about patients with decompensated cirrhosis? and this is very important in countries which don't have transplantation. Can we use DAAs in patients with decompensated cirrhosis? Well, we look at which drugs are safe, which drugs are metabolized by the liver. This is Child-Pugh-A, Child-Pugh-B, Child-Pugh-C. You can see that the protease inhibitors, you get massive increase in exposure in patients with Child-Pugh-B and Child-Pugh-C, and that is associated with hepatotoxicity. So protease inhibitors cannot be used in patients with decompensated cirrhosis, and neither could the old non-nuke polymerase inhibitors. This was a drug in Vicarapac. So you can't use protease inhibitors. You can use NS5A inhibitors and sofosbuvir, neither of which are metabolized by the liver. This is the first study treating people with decompensated cirrhosis. This is ledimosivir, sofosbuvir, plus ribavirin. And this shows that people were cured regardless of how sick they were. Child-Pugh-B, 89% cured. Child-Pugh-C, 81% cured. I should point out that modified intention to treat, most people were actually cured. The low SVR rates were because of the large number of people who died because of their underlying liver disease. Of those patients who didn't die, most were cured by this antiviral treatment. If you look at all genotypes, sofosbuvir plus velpatasvir, again, this is looking at Child-Pugh-B, a subsequent study in Child-Pugh-C, same results. They looked at 12 weeks with or without ribavirin, or 24 weeks without ribavirin, and you can see that the middle arm, the 12 weeks plus ribavirin, was the most effective. And so this is the recommended treatment, sofosbuvir velpatasvir plus ribavirin for 12 weeks in patients with decompensated cirrhosis, including genotype 3. And that is the treatment of choice in decompensated cirrhosis. When you cure someone, you get an improvement in liver function. This is shown by an improvement in Child-Pugh score by 24 weeks post-treatment, by up to 5 points. And in this study, when you looked at people on the waiting list with liver failure in Italy being cured, up to half of them were able to come off the waiting list. So when somebody has liver failure from hepatitis C and you treat them, almost half of them will get better and not need liver transplantation. This is a dramatic effect on liver transplantation around the world, where up until recently, hepatitis C was the main indication for transplant, and this is especially in Australia and New Zealand. The numbers of transplants we've done for hepatitis C have reduced by 75%. This is a huge evidence that treatment for hepatitis C is of great benefit, no matter how sick patients are. In patients after kidney or liver transplant, it's also easy to treat them. First, you have soft bowel, very simple to treat, no real drug-drug interactions. Cure rates the same as patients without transplant. 98% of patients were cured after liver or kidney transplant. The same in the study I was involved in with glucapavir, providusvir. This is in both liver and kidney transplants. 99% were cured. So most liver transplant centers now have eradicated recurrent hepatitis C. So we've treated everyone after transplant who had hepatitis C with a kidney or liver transplant, and now we're treating everyone before transplant. And this is a huge change within just 3 or 4 years. Finally, the last difficult to treat population are patients with co-infection, patients with HIV and hepatitis C co-infection. And that is very common in certain parts of the world, especially in people who inject drugs. And I realize that you have a certain population of patients with hepatitis C and HIV in Dakar who have got both infections from injecting drugs. So they used to be very hard to treat. I'm going to show you they're now very easy with the same 2 treatments. Sofosbuvir velpatasvir plus 12 weeks. Over 100 patients in this phase 3 study from Gilead. And you can see that in patients with co-infection, most of them were cured with 12 weeks of soft bowel. Overall, 95% of patients with HIV co-infection were cured regardless of genotype. And in the other study with the glucapavir preventosvir for 12 weeks, this is called the Expedition 2 study, 12 weeks of treatment, 99.3% of patients were cured regardless of genotype. So HIV co-infection doesn't matter anymore. The only thing you need to look for is the drug-drug interactions with the antiretroviral treatments used for HIV. And the most important ones are the non-nuke or reverse transcriptase inhibitors and the protease inhibitors. So these are a problem with glucapavir preventosvir and with sofosbuvir velpatasvir. But if you look at the most common treatments used around the world for HIV, this is sofosbuvir containing regimens and the integrase inhibitors. These are easy to use. There's no significant drug-drug interactions. But if your patient is on Truvada or Atripla plus an integrase inhibitor, you can use Sofvel and Glupib without any problems whatsoever. So I'd like to finish now by summing up. Oh no, just to say, if you want to look for drug-drug interactions, there is a free drug-drug interaction website you will be all aware of with the Liverpool website. You put in Sofvel or Glupib, you put in your HIV medication, it'll tell you whether it's safe or whether you have to swap treatment. So I'd like to finish now by summarizing hepatitis C treatment for special populations. Seems to have become much easier over the last 3 years. In patients with chronic kidney disease, including those on dialysis, treatment is very easy. We can use all of the medications you have available in Bangladesh. They're safe and effective, and the dosing is the same as it is in people with normal renal function. If you look at patients with HIV infection, treatment is easy. All of your medications can be used, they're safe and effective, and the dose is the same as in people without HIV. In patients with kidney, and liver transplants, treatment is easy. All the medications you have available are safe and effective, and the dosing is the same as in patients without transplants. In patients with liver failure, you have to avoid glucapavir preventosvir because it has a protease inhibitor. But all your other medications are safe and effective. The effectiveness is not as good as in people with normal liver function. So you either need to extend to 24 weeks or add ribavirin. But you can treat most of your patients with liver failure and they will improve and survive without liver transplant. I'd like to finish by saying that in 2021, there are very few unmet medical needs with the generic drugs you have at your fingertips in Bangladesh. I'd like to finish by thanking many of my colleagues and friends who provided slides I've used in this presentation, and I'd like to thank you, the audience, for your attention.
Now I would like to request Professor Dr. Muhammad Firoz Amin to introduce the second speaker and continue the session.
Thank you very much. So after the wonderful lecture of Professor Evgen, it's my pleasure to introduce Professor Jacob George, who is the professor of the hepatic medicine at the Storr Liver Center, Westmail Institute of Medical Research, University of the Sydney. He is the founding member of the Asia Pacific Region and Advisory Council to the AASLD, the Global Outreach of Engagement Committee. He'll talk on the one of the very demanding subjects nowadays we're dealing with our clinical practice, that is the NAFLD NASH Diagnostic Treatment and Monitoring 2020. May I request Professor Jacob, please start his deliberation. Thank you very much.
First of all, thank you very much to the organizers for asking me to speak today. And it's a pity that I can't be in person. A lot of the emails that I get come from Mobin Khan, and I don't think many of you will know that Mobin and myself actually worked together. I was an intern, and he was involved in working with Laurie Powell. So I do know Mobin quite well, and it would have been a wonderful opportunity to meet. So my challenge today is to talk about metabolic dysfunction associated fatty liver disease and MESH, or metabolic steatohepatitis. And if I could suggest that we should not be using the term MAFLD and MASH anymore, it should be MAFLD and MESH. And I'm going to cover, as requested, only the diagnosis, monitoring, and treatment of this disease. So very straightforward overview: diagnosis, monitoring, and management in 2021. As you all know, with the new drugs coming, we may have different management over the next 5 to 10 years. So what is the problem with NAFLD, and why do we need to change the term from NAFLD to MAFLD? And these are some of the few problems that I've discussed on the slide. So the first and most important problem with NAFLD is it's a diagnosis of exclusion. In other words, you diagnose it when you've checked every other liver disease, and if the patient doesn't have any of those diseases, then it's a wastebasket, and you say, okay, the patient has got NAFLD if they've got fat. So the problem is there is no means of objective proof of the disease. If you don't have a set of diagnostic criteria, then it captures a heterogeneous patient group. And if you capture a heterogeneous patient group, the name has no link to the pathophysiology whatsoever. And if we cannot define an individual phenotype or disease except by exclusion, then it's no surprise that we don't often get an adequate response to therapy, which is what we see in clinical practice. And with the diagnosis of exclusion, we're stuck. We want to biopsy every patient because the histological criteria are the ones that determine whether you enter into a clinical trial. On the other hand, as Ed just talked about with hepatitis C or with hepatitis B, the treatment and the drugs we use are based on a positive diagnosis. Whereas here we're looking at liver histology and then saying, oh, they must have steatohepatitis. Particularly in Muslim countries, the term alcoholic in the name trivializes and discriminates. It's also problematic for children. And recently, the International Society for Tropical Diseases, Pediatric Diseases, have endorsed MAFLD. We also know in published literature there's a lack of awareness among patients and healthcare providers, including specialists, about what NAFLD is. And finally, the term NAFLD fails to align with the other associated diseases. And by that I mean that we talk about diabetes, chronic kidney disease, cardiovascular disease, obstructive sleep apnea, to name a few. So what is the new name? And as you know, a group of international experts in the field came up with the name. And the new name is MAFLD, or metabolic dysfunction associated fatty liver disease. We actually asked, and we got about 21 different names that were suggested, that were voted upon, and MAFLD was the top choice. And I think MAFLD was the top choice because it gives a simple recognition of the fact that for 40 years it's been NAFLD, and we've just changed a single letter and easy to roll off the mouth. So the new name is metabolic dysfunction associated fatty liver disease. Now, as you would know, if you have a new term like NAFLD, it's not an advance just by giving it a new name. We need to overcome all of those negative aspects that I discussed with you earlier. And so we came up with a definition. Simple. It's a set of positive criteria, and it can be used in all settings, including rich countries, poor countries, centralized health systems, private practice health systems. And the two papers have now had more than 2,000 citations, and we've stopped counting. So what is the positive diagnosis? And as you can see here, if you have hepatic steatosis and you're overweight or obese, you have MAFLD irrespective of whether you've got another liver disease. We have type 2 diabetes and steatosis, any mechanism here, imaging, biomarkers, or other scores, you've got MAFLD. If you're of a healthy weight based on ethnic criteria, and in Bangladesh, you know, it has to be about less than 23, and you need at least 2 metabolic risk abnormalities. So this is a very easy definition for all countries, and it clearly aligns the disease to metabolic dysfunction, hence the name, it's metabolic dysfunction or dysregulation associated fatty liver disease. And I believe that the traction we've had with over 2,000 sites in just a single year reflects the fact that it makes sense to people. So let's now move on and look at differences between NAFLD on the left-hand side and NAFLD. Is there any link to disease etiology? With NAFLD, there's none. It's a basket case. With NAFLD, we say you need metabolic dysfunction, then you've got it, whether you have any other disease or not. Does it capture the heterogeneity? And as I showed you in the previous slide, it does. We've got those 3 separate criteria, and we exclude patients who do not have metabolic dysregulation. Can you identify it in the presence of other liver diseases? Of course you can, but you can't with NAFLD. If you've got hepatitis C, you can't say you've got hepatitis C and NAFLD because you haven't excluded all other liver diseases, which is intrinsic in the name NAFLD. Does it allow disease stratification? Yes, it does. NAFLD doesn't. Does it identify patients with more severe hepatic and extrahepatic disease? It does, and I'll show you some examples. Does it impact the histological criteria that we've been using when we look down the microscope? For both diseases, we don't. What you see under the microscope is what you see, and you can use any score that you want for steatosis, inflammation, and fibrosis. So it doesn't impact histology. Does it provide a framework for monitoring our patients? Yes, it does. So in an overweight person, we can talk about diet and weight. In a lean patient, we can talk about metabolic dysregulation. For all of them, we can look at what metabolic criteria they have. When you increase awareness, you accelerate drug development. Does it reduce stigma? Of course it does. Does it increase awareness? It does. Does it provide a framework for precision medicine? It does, because the drugs that we may use for lean fatty liver disease are very different from diabetic MAFLD or obese MAFLD. Finally, is it useful across health systems? And it is. So you can see this is precisely the reason why the name has just taken off. And this is an editorial that was published very recently by Professor Alam from Bangladesh. And he's really, again, reiterating the positive implications. It overcomes the dichotomization of NASH and non-NASH, facilitates diagnosis and evaluation, increases awareness, and these are not just statements that he's just pulled up off the top of his hat. There are, if you look among those 2,000 papers, there is evidence for all of these. Does it improve physician-patient communication? It does. There are papers on that. Does it improve clinical diagnosis and care? It does. Does it reduce confusion and stigma? Yes, there are papers about it. And does it increase public attention and improve health policy actions? And it does. I'm so grateful to Professor Alam for sharing his recent paper with me. Now, this is some of the proof. So this is a study from the NHANES dataset published by Mindy Nguyen, 12,000 patients across the US. If you look at it on the left-hand side, this is the group that would meet both definitions, 75%. It's about 10% on the left that wouldn't be classified as having MAFLD because they don't have metabolic dysregulation. And here there's about 17% of patients who would have MAFLD but not MAFLD. So you can't have MAFLD and Hep C. Okay? So these are MAFLD, and these are patients with MAFLD but not MAFLD. Most of them have hepatitis B or C or celiac disease or autoimmune liver disease. Now, if you look at all-cause mortality, cardiovascular mortality, cancer-related mortality, or other cause mortality, in the green, you have these 17 patients, the ones who have 2 liver diseases. And then in the brown, you can find people who are the overlap of 75%. And these are the non-MAFLD group. So for every single criteria, the MAFLD criteria performs better, while people without metabolic dysregulation have a very low incidence of adverse events. And, I would suggest that this is actually even lower because this was based on a single baseline study. Well, what about extrahepatic manifestations? And the data is exactly the same. This is, would you believe, a study of 9.5 million Koreans looking at incident cardiovascular disease, and I wrote the editorial for this in CGH. And again, same sort of idea, mixed disease, MAFLD only. And as soon as you have the MAFLD definition, you diagnose an extra 10% of people that's in the brown. Now, when you're looking at extrahepatic disease, the Hep C and Hep B and autoimmune hepatitis have a very small impact on extrahepatic disease, but metabolic dysregulation has a major impact. And that's exactly what you see, the reverse in the previous slide, where the highest risk are the people with MAFLD and metabolic dysregulation. Next is the one with the mixed group. They do have an increased risk because they've got metabolic dysregulation. And those with NAFLD only have a minimally, if not no, increase in risk. I won't bore you, but in kidney disease, it's exactly the same. Increased risk of kidney disease in the patients with MAFLD because it's a disease of metabolic dysregulation. And this was a paper that just been published in J Hepatology Report today. I know that in Bangladesh, hepatitis B is common. There are other papers with the same thing, looking at patients with hepatitis C. And this is looking at MAFLD and hepatitis B. So there were 780 patients without MAFLD and 300 patients with MAFLD. And you looked at event-free survival. If you did not have MAFLD in this group of patients with hepatitis B, and this was a study done in Europe, there's no significant, there's a very small decrease in event-free survival. But if you have hepatitis B and MAFLD over the next 20 years, as you will see, there's a significant number of clinical events. And it shows you that it's MAFLD that's important. Steatohepatitis is important just for liver-related events, but the MAFLD, the metabolic dysregulation, is important for event-free survival. Now, this is just summarizing for a talk all the papers that have been published, and this is done by my colleague Hua Zhang in China. These are looking at studies looking at liver-related outcomes on top and looking at extrahepatic morbidity on the bottom. And in every one of these studies, in not a single study, does NAFLD outperform MAFLD for hepatic or extrahepatic morbidity. A couple of studies, they're equal, but they're typically the studies that have got a small cohort size. In anything with a large cohort size, MAFLD performs. We already, just 1 year after its publication, we already have data on the global prevalence of MAFLD. And it's very, I guess it's not surprising in some ways, but in Eastern Europe, 81% of patients MAFLD. In East Asia, it's half the population. In India, it's 50%. And I dare say in Bangladesh, it's going to be much the same. In South America, 70%. We just need to walk around the streets in our countries, and we will agree that this is a more realistic estimate than the NAFLD prevalence estimates. And then going back to the definition, and you look at the company it keeps in patients with NAFLD, 20% have diabetes, abdominal obesity is present in 84%, insulin resistance in 41%, blood pressure in 42%. So it is a disease of metabolic dysregulation, and it best describes the disease see in clinical practice. I'm just going to have one slide on pathogenesis, just to say that MAFLD is not a liver disease in isolation. It's actually a disease of meta-inflammation. In other words, inflammation in all tissues. As your body weight increases, your immune homeostatic signals decrease and your pro-inflammatory signals increase. So in the brain, you get hypothalamic inflammation. You get inflammation in adipose tissue. We see the patients with inflammation in the liver. There's inflammation in muscle. There's inflammation in blood vessels that gives you your heart attacks. And there's inflammation in your pancreas and your beta cells that give you the diabetes. So it's not a disease in isolation that just one organ. It's a disease of systemic metabolic dysregulation. Now, just for the second part of this talk, in terms of the management of this disease, this is a population-based study, 12,000 patients from NHANES in the US, and they looked at people with advanced fibrosis diagnosed on the NAFL fibrosis score. It was called the NAFL fibrosis score, and I was involved in developing it back with Paul Angelo in 2007. And when you look at the cause of death over the next 15 years, the key thing I want to make you mention from a population perspective, only 2%, 2 in 100 people, will die from their liver disease. 98% die from cardiovascular disease, diabetes, or cancer. Again, telling you that this is a systemic disease in which the liver is just but one organ that's affected by the meta-inflammation. And to highlight the point again, if you look at liver-related outcomes, this is a meta-analysis according to fibrosis stage, liver-related outcomes only increase when we go to F3, F4. We see that all the time. But if you look at the left slide, and you're looking at all-cause mortality, and this is all cancer-related mortality or cardiovascular mortality, as soon as you have metabolic dysregulation, even F1 fibrosis, your risk increases, and this is what's actually shown on this slide. One slide on how we monitor for MAFLD. I think if you have cirrhosis and perhaps high-risk patients with a lot of metabolic dysregulation with F3, I would undertake liver cancer surveillance, paraceal surveillance, perhaps using the Baveno 7 criteria, which has just come out in the last couple of weeks. You need to look at bone health. If you've got F0 to F2 based on a FibroScan or other tests, patients are best managed in primary care, but we as liver specialists should see them probably only once in 3 to 5 years. And what should we do? We should do a metabolic assessment, and I'll come to that in a minute, a FibroScan, liver tests, coag profile, all the usual things that we do. But we don't need to see them often, as long as our primary care physicians are well educated. And this is a Journal of Hepatology publication on such an algorithm in primary care based on a FIB4 level. They had a second thing, but you could go FIB4, high FIB4, do a FibroScan, refer to a hepatologist, low FIB4, see them once every 5 months. So how do we manage MAFLD? And as you all know, if you can measure something, you can manage it. And this is a statement by a famous mathematician and astronomer and a doctor, who's the only pupil of Nicholas Copernicus. And I think it's very apt. And so it tells us how we should be managing MAFLD. We need to measure things because we're not only treating the liver, we must be aware and treat the whole patient. So when I talk about a metabolic assessment for MAFLD, we need to think about talking to the patient, even if it's 5 minutes, smoking, alcohol, diet, and exercise. It's a journey that you're going to be on with your patient. We need to ask about their blood pressure. We need to ask about their obesity, dyslipidemia, and type 2 diabetes. And compared to 30 years ago, at least as hepatologists, to manage the patient, have got very, very distinct targets for all of them. And so for type 2 diabetes early in the disease, you must communicate with the primary care physician, or if you're comfortable, as I am, with giving diabetes treatments, you want an HbA1c of less than 7. You want an LDL cholesterol of 1.8 or less and a triglyceride of 1.69 or less. And the earlier you start your lipid-lowering treatment, the better it is. And with cholesterol, now they're saying we should be starting it in teenage, because what gives you atherosclerosis is lifetime risk. And again, blood pressure. It should be less than 130 on 80, and we shouldn't be accepting anything higher than that. With obesity, liver steatosis improves with 3% weight loss, inflammation with about 5%, NASH resolution with about 7%, and fibrosis improvement with about 10%. And all of that is important. Now, just to try and put the context of obesity to all of you, and I don't know whether many of you know about this, but when you think about a human appetite, we've only got 5 appetites. We have an appetite for protein, we have an appetite for carbohydrates, fats, sodium, and calcium. We don't have an appetite for chili and ginger, and we don't have appetites for triglycerides specifically, or cholesterol, or molybdenum, or zinc. There's 5 appetites. And then you ask the question, well, why do we eat? The surprising thing is, we eat not because we want calories, we actually eat to get sufficient protein. So protein is the key driver of appetite. The body wants protein, not calories. And just to show you this thing about appetites, I'll just show you this little picture here. This is in the Alps, and this is the dam, water at the upper end. All these little dots are ibex. And what they're doing is they're actually licking for salt, because salt is one of the appetites in animals and in humans, and it makes sense because all our cells are made from salt. So why do we get obesity? As I mentioned, the appetite is for protein. It's not for calories. So this is the very simple explanation that is relevant for your children, even from birth. So let's imagine a patient is eating a balanced. He gets this amount of protein, and he says, I'm full. And when he's eaten that amount of protein, he's eaten this amount of non-protein energy, which is carbs and fats. Now, if you eat an unhealthy, processed diet that's got very little protein, what you can see here is to get the same amount of protein, you now have to eat up to here. So to eat up to here, what are you eating on? To get that protein, you're eating carbohydrates and fat. And that very simply is the cause for obesity. Having a diet that's very low in protein, and that's because we're into eating processed foods. And if our children eat natural foods made at home, it wouldn't happen. And this is further proof of this. This is a group of wild animals, not a single